Join us for the 2025 n-Lorem Nano-rare Patient Colloquium, hosted by Biogen, this October 20th and 21st in Cambridge, Massachusetts. Connect with members of the Nano-rare community as we explore the latest from the Foundation, share insights from treated patients, feature expert-led panel discussions, and more. Supporters, physicians, scientists, and patients and their families will come together for 2 inspiring days of learning, connection, and hope. Don't miss it. Register now to attend in person or virtually at n-Lorem.org.
This episode of the n-Lorem Patient Empowerment Program podcast is proudly sponsored by Hanjin Biotech. With more than 26 years of experience in the nucleic acid industry, Hanjin is a specialized CDMO and raw material supplier committed to providing high-quality and high-value products and services with the best-in-class lead times.
Hello and welcome to the n-Lorem podcast series, a series that focuses exclusively on patients now referred to as having nano-rare mutations. I'm Stan Crook, and I'm the founder, chairman, and CEO of n-Lorem. n-Lorem is a nonprofit foundation that I initiated in January of 2020. Our mission at n-Lorem is to take advantage of the technology we created at Ionis Pharmaceuticals, antisense technology, or ASO technology, to discover, develop, and provide experimental ASO treatments to nano-rare patients, and to do that for free for life. You know, at n-Lorem, we have very limited resources, and the investment decisions we make can and often do directly affect the lives of our patients. So we are very careful and try to think deeply about every decision to invest. And we understand that the capital we have is very precious and is the product of many generous donors and partners. Given that, a fair question might be, should we be investing in basic research to advance ASO technology? Certainly, most of the money we have should and does go directly to creating ASOs that can help patients today, because our patients need help today. But I believe that we also must invest in advancing ASO technology so that in the future we can help more patients and make even better ASOs. In this podcast, I plan to discuss this topic. Why is basic research in ASO technology important for n-Lorem to do? Introduce you to some of the work that we are doing. Despite limited resources, and they are very limited, we are making an important progress that will mean a great deal to patients in the near future. Unlike other fully validated drug discovery technologies, ASO technology is still evolving, and evolving fairly rapidly. Small molecule drug discovery, the backbone of the drug discovery industry, is 125 years old. Monoclonal antibody technology is more than 50 years old, and it was the work of many companies, many academic scientists. And gene therapy has been underway for more than 40 years and consumed more than $40 billion worth of investment in many, many companies and multiple academic labs. And it's fair to say that small molecule drug discovery has really not undergone a profound shift, a significant across-the-board advance in many decades. And monoclonals are now pretty standard, pretty staid, really not evolving. Gene therapy, as I mentioned, has had an enormous commitment and investment of more than $40 billion, is still not addressed the core problems of gene therapy, which include immune activation, delivery and maintenance of long-term therapeutic effect while avoiding integration into the patient genome, and cost. These are all still major challenges and great impediments to adding gene therapy to the repertoire of technologies that we might use to treat nano-rare patients. ASO technology, in contrast, exists because of a single company, Ionis, and only recently have other companies entered the space, and only recently has top-flight academic labs become interested. And so it's a very different history, and the present is also very different because the technology, while fully validated, still has very obvious opportunities to get even better, even more versatile, even produce better drugs. Now, our nano-rare patients are benefiting enormously from the ASOs that we've provided so far. We're very proud of that. But our nano-rare patients need more from the technology. Today, we're able to say yes to only about 50% of the patients who apply for treatment. That leaves 50% of the patients without hope, without any opportunity to get better. And so, again, that's great, but what about the other 50%? Well, even for patients to whom we can say yes, there are, in addition, some patients for whom ASO drug discovery is much less efficient than we'd like, and on occasion we fail. So there's more to be done, and much more that we need this technology to do for us. And as we've come to better understand the unique needs of our patients, and I'm going to walk you through some of the reasons that we have to say no, and why sometimes we fail, and why sometimes it take a long time to get the job done, I think it'll be clear to you why, even in a very limited financial scenario, it's urgent that we invest in advancing the technology. And I'm going to convince you that we are making great strides despite very limited funding. So what are the main reasons that we're unable to say yes to treat nano-rare patients who apply for treatment? Broadly speaking, there are several limitations of the technology today that lead to our inability to help specific patients. The most challenging problem for us is loss of function mutations. And a significant fraction of our patients suffer from loss of function mutations. But only a small fraction of those patients actually have true null mutations. That is, mutations that mean they make none of the needed protein. If a patient has a null mutation, then at some point gene therapy may be the answer. However, many loss of function mutations result in the production of a truncated or dysfunctional protein because of missense mutations in the coding region or in the non-coding region of the RNA. We now know, thanks to recent advances, that for many of these partially truncated proteins or mistake proteins that are made, there are potential solutions that are amenable to ASOs. And if we could address that challenge, we could help many more patients. The second big reason we have to say no is that the mutation causes a dysfunction of an organ to which ASOs distribute only at high doses. Today, we are willing to treat CNS diseases intrathecally, eye diseases intravitreally, and liver and kidney diseases subcutaneously. We're unable to help patients with heart, skeletal muscle, gut, immune disease, or cancer, because we feel that the doses we must use in those organs are simply too high to assure that we can treat our patients safely. So this is probably the second most common reason that we're saying no. A third issue that causes us not to say no, but to lose ASOs that we are developing, especially for the central nervous system, is innate immune activation. The innate immune system is the most primitive of the immune mechanisms, and every cell throughout your body is capable of mounting an innate immune response to foreign DNA and RNA, and ASOs are nucleic acids, and so they're recognized as foreign, and they can, if they're not properly designed, can cause innate immune activation. And because we can't control innate immune activation as much as we would like, today we can't treat lung diseases. And there are many, many disease opportunities there. We help a lot of patients. And we lose a good many ASOs in development because of innate immune activation in the central nervous system. And obviously, the more efficient we can make ASO discovery, the fewer ASOs that fail, the more we can do with our very limited dollars. And so any step that would help us avoid innate immune activation or reduce the risk of innate immune activation is going to make better drugs for our patients and mean that we can be more efficient and spend less to make more, to do more. So it's a big deal. The final major scientific factor is the challenge of creating allele-selective ASOs. About 50% of our patients have heterozygous toxic gain-of-function mutations in essential genes and therefore require allele-selective RNase-H1 ASOs. While I think we do a really good job at this today, the process is labor-intensive, it requires screening of many hundreds of ASOs, and it sometimes fails. To design allele-selective RNase-H1 ASOs, we first have to identify non-pathogenic single nucleotide variants and use those to design our ASO. So in a small gene, where there may be very few non-pathogenic variants, we often don't have enough opportunities to make a good ASO, even if we screen all of them. And if there's only a single non-pathogenic variant, it's almost always impossible. So that's a significant limitation, particularly since so many of our patients require allele-selective ASOs. Not only that, but some genes, like ion channel genes, require very high allele selectivity. And that makes it even more challenging. If we have to have a 20-fold selectivity for the mutant versus the healthy copy of the RNA, that's harder than if we have to have 10x. And so anything that we could do that would make better allele-selective ASOs and make the process more efficient would allow us to help many more patients. Okay, so what about solutions? What are we trying to do to solve some of these things? Well, let's take each of these one at a time. Loss of function mutations. One of the most exciting areas in molecular biology right now over the last few years has been rapid progress in understanding the control of translation. And you control the translation or the making of proteins because you have to, cells all have to respond to stress. And there are some proteins you don't want to make if you're stressed and some other proteins that you do. And the most rapid way to change all of that very efficiently is to alter translation itself. That is, go into the factory that's making proteins and order a different protein to be made and order another protein not to be made. That happens constantly. Otherwise, none of your cells survive all the stress that they have. And so this area was literally unknown 20 years ago. And today, we now know that there are multiple ways that the production of specific proteins is regulated. And those provide extraordinary opportunities to treat some patients that we currently can't treat. So the areas that are controlled are first transcription of the RNA. You can control transcription. That gives you control of how much RNA. That gives you control of how much protein is made. Then there are sequence elements in RNA itself called UORFs and TIEs that directly reduce translation of specific proteins. 60% of all your RNAs that are used to make proteins have some of these elements in them, meaning that you make less of the protein most of the time than you actually could, okay? Why? Because in a period of stress, you want to be able to immediately make more of those proteins. So you don't need all that protein when everything's easy going. It's like you don't need a raincoat if it's not raining, but you want to have a raincoat. This is your raincoat. This is your umbrella, okay? And then there are new mechanisms that are emerging constantly. Fortunately, my lab at Ionis pioneered the work that led to the understanding of the molecular mechanisms by which ASOs produce the effects that we observe. And specifically, my lab published the basic advances in understanding how ASOs can be used to affect splicing, poly-A site usage, which determine how stable the RNA is, which in turn determines what proteins are made and how much, how to use UORFs, how to use TIEs. These are all things that we've done. But the processes are still very inefficient. And what's happened over the last few years is we now understand the minute molecular details that underlie each of these things. And that gives us extraordinary opportunities to do better, to be more efficient, reduce the amount of screening and the time and the dollars that we have to waste making bad drugs and make only good drugs. And so we're working very hard in this area. Now, this is an enormous task, but even with the very limited resources that we've been able to put on it, we're really making excellent progress. And we're about to submit a couple of papers that will demonstrate that. So I'm confident that we will make very fundamental advances in this area, and they will, in the longer term, ensure that we can treat more patients, that we can do it far easier and cheaper and faster, which means we can treat more patients and we can make better drugs. So this is work that's ongoing. It's important, and it will have an impact on the health of many, many nano-rare patients. So to put specific numbers on it, if we can really make advances across the board in this area, I think there may be 30% more patients we could treat. Think about that. 30% more patients. That's a large fraction of the people we have to say no to. And so if you're looking for a high leverage way to invest nonprofit dollars, charitable dollars, this is where we need your help. We could use some funding here. It's just a matter of manpower. We know what to do. We know how to do it. We are pioneers in this area. With a little more money, we can solve all this. Now, a second area that's underway broadly in the industry, but not at n-Lorem, is targeted delivery to muscles, the heart, the immune system, the gut, and cancer. And obviously, any advance that would open up a new organ opens up a whole set of patients that we can't treat today. So we'd love to make progress there. And there is progress being made. However, as I said, many companies, almost everybody in the field, including Ionis, are pursuing this. Research in this area is super expensive because it has to be done in large animals, monkeys. So it's very, very expensive. And we think the problem is going to be solved by companies like Ionis, and we can't afford to invest in it, but we are actively encouraging others to invest. We're watching the progress, and we'll jump in and try to take advantage of the progress for our patients when the time is right. We'd love to invest in this area, but it would just siphon off too much money from immediate treatment of our patients. Now, controlling the innate immune system. Once again, my lab made quite significant contributions in this area. In fact, most of the molecular mechanistic understanding of why ASOs activate the innate immune system came from my lab, 3 or 4 papers over the last few years. So we're very well positioned to address this issue, and we've already made really important progress. In fact, we just submitted an important paper that for the first time answers the question of how cells turn off their innate immune system when it gets activated. If you think about the immune system, you need an on and an off switch. You need to respond to some threat like virus, or DNA, or RNA. You need to respond, get rid of it, but then you need to terminate that. If you don't, then you get chronic inflammatory disease, and chronic inflammatory disease accounts for about 50% of all Western deaths. Heart disease is largely a chronic inflammatory disease. So we, for the first time, have addressed how, if a ASO stimulates the innate immune system, the cell terminates it. And we now know that this process requires the shift in the metabolism of an amino acid called tryptophan to an oxidative pathway. Those products then shut off the genes that make the immune response go. So we already understand that, and that's what this paper shows. It's very, very exciting. And these oxidative products of tryptophan are small molecules that we could, in principle, actually include in formulations of ASOs to reduce or prevent innate immune activation. That might enable us to be able to treat lung disease, aerosol, and it will reduce the risk of side effects in our patients. And it will mean that we'll lose far less ASOs because we can weed out the bad performers before we make them. So great efficiency. We think that the impact of the advances we're already making is going to be profound. We believe strongly that we're making progress that will enable treatment of more patients, better treatment of all patients, safer treatment of all patients, and those advances will build on each other's, enable us to do more, better, faster, cheaper, which is the goal. The final area in which we're making important progress is enhanced alloselectivity. So the reason we can design an ASO that selectively degrades only the mutant RNA and not the normal RNA, and therefore only reduces the mutant protein, not the normal protein, is that all of us carry around about 300 million non-pathogenic single nucleotide variants. And the longer the gene, the more opportunity for these variants. And so long genes always have maybe 10 or 20 non-pathogenic variants we can use. Some short genes may only have one or none. And we're doing a good job of that. And as I mentioned, about 50% of our patients require allele-selective H1 ASOs. But we are perfectly positioned to take advantage of what's been learned to be able to do this much better. Because the principal reason for the selectivity is the unique properties of the enzyme RNase H1 and its preference for certain types of sequences that it likes to cleave best. And my lab essentially published all the data about the enzymatic activity, the nature of the enzyme, the involvement of the enzyme in ASO activity. So we are among the world experts in RNase H1. So we're very hard at work at this. And as we make progress there, again, we'll become much more efficient. We'll make better ASOs and safer ASOs, and we'll be able to dial in the selectivity we want. So even if something requires 20-fold selectivity, it won't be daunting. So these are all important investments. So in conclusion then, absolutely yes, our patients' needs demand that we invest in advancing ASO technology. And we are uniquely positioned to do that because this is the area I led for the last 35 years. And the team that we have is doing a great job of advancing each of those areas. That said, we must invest in only those efforts that will have a large near-term impact on many patients, and those efforts that are affordable, not being pursued effectively by others and for whom we bring unique expertise. That's the sort of decision metric that we use. And I would add, once again, that if you're looking for high leverage, how to spend your charitable dollars in a way that could help not one patient, but thousands, this is an area of investment where we could really need your help because it's really just a matter of hands in the lab. We know what to do. We know how to do it. We are the leaders in this area. So with added funding, the progress would simply be exponentially better. We'll continue to do our best. We're very proud of the advances that we're making, and we're committed to doing our best for patients today and being able to do more, better, faster, cheaper for patients in the future.
n-Lorem is a nonprofit committed to discovering and providing personalized experimental treatments for free, for life, to patients with genetic diseases that affect 1 to 30 patients worldwide, referred to by n-Lorem as Nano-rare. Many of these patients progress and die without ever achieving a diagnosis. This is where n-Lorem comes in. They do the impossible by providing hope, and for those that they can help, free lifetime treatment. For more information about n-Lorem or today's episode, visit n-Lorem.org. Any questions can be sent into podcast@n-Lorem.org. Search n-Lorem on Twitter, Instagram, YouTube, LinkedIn, and Facebook to connect with us. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allows others to find the show. This podcast is hosted by Dr. Stan Crook. Our videographer is John Magnuson of Mighty One Productions. Our producers are John Magnuson and Kira Deneen of DNA Today. Thank you for listening.